Tēnā koutou katoa, everyone. Welcome to tonight's session with Dr. Don Matheson, titled Is COVID-19 a Health System Reformer? It's a great pleasure and a delight to have Don here with us tonight. Mary and I go back a long way with Don to the time when he took over from me running a crash pad in Berhampore, for which I was extremely grateful. And then went on to, with Julia, work in rural Zimbabwe, and came back to be the first doctors at the Newtown Union Health Centre, which was another groundbreaking episode in New Zealand's history of health provision. So, and later than that, has worked in the health department in the past, has been consulting through the Pacific, been teaching at universities in Brisbane, and did a brief stint here back in the health department where he no longer is now. So I'm really looking forward, Don, to tonight, to what you have to say with us about reforms in the health system, because there is a lot going on, and I'm sure there's a lot more that needs to be going on. So welcome and thank you.
Thank you. Thanks for those words of introduction, Mike. Mike was referring to 1973, if you were wondering about when we first met. And I won't go into the details because Mary will get embarrassed. That's really the issue. Thanks for the opportunity to meet and discuss with you tonight. These meetings are really important, I think. Lots happens, but not a lot of thinking goes on, I'm afraid. And so trying to create opportunities to think more deeply about some of the issues and the challenges is probably the one way we've got to sort of ways through the immense challenges we've got. I haven't got that. Oh, here we go. Yeah, so I thought I'd start when I last talked to this audience in 2016. You remember that? And I talked about these characters with Bob Kerr's paintings. This was Nordmeyer, Macmillan and Davidson, the teacher, the parson and the doctor in Kurau in the 1930s, where economic refugees from the North Island were coming to Kurau with spades on their backs, hoping that the government would employ them on building a dam. And that was this was a wee bit before fossil fuels became a problem, but it is a hydro dam and it's still going today. But these three came together and looked at solutions for what they saw, extreme poverty. They saw kids shivering in the Waitaki Valley. I was brought up around there, but it's a pretty cold and bleak place if in that area. This is going to be an issue. And anyway, they built it. They looked to think about what a health system could be. And how it would address health and the determinants. And as I'm sure you know, they felt that it should be a scheme based on justice rather than charity. And every health services up until then were largely a charity mode. And it was very innovative in thinking, and according to Keith Sinclair, the historian, the 1938 Act that arose from it, it was seen as the first comprehensive and integrated system of social security in the Western world. So it was truly extraordinary. Their ideas about a health system were pretty straightforward. It should be about prevention. It should be free. It should be comprehensive, and it should apply to all. It should have choice. It should cover diagnosis and treatment of conditions. There should be a choice of doctor, but they said at the time, and it should be underpinned by research. So that was a pretty good sort of frame for them at that time. In this presentation, I'll be talking about the health reforms. These three were engaged in, it was called the Kurau Cure. We're in the midst of our attempt at the Kurau Cure as I speak, and so I just wanted to start with those early reformers and think of the current reforms. We've got the Health and Disability Systems Review, which was led by Heather Simpson. The team that in that review addressed some of the gender mix that was missing from the three in Kurau, some of the ethnicity mix missing from the three in Kurau. The professions involved have changed a bit. They've replaced the minister with a captain of industry. The teacher was replaced by academics. The doctor was replaced by a broader range of health workers. So we've moved a wee bit on since then in that respect, but I do think that the blueprint that they put forward at that time still holds a lot of water. The Health and Disability Review was very extensive, and in terms of a problem, it was most people in the sector feel they described it pretty well. But they produced their report just after the start of the COVID pandemic. And what they found, of course, was there's consistently bad outcomes, particularly for Māori, Pacifica, people with disability, and that the system lacked leadership, and coming from that, we have moved now to, Parliament has, to develop a bill called the Whanaura Bill, and that's currently under discussion and in the House for its second reading sometime soon. Now, the key things that the Health and Disability Systems Review said, that they want to ensure consumers and whānau and communities at the heart of the system, that there be culture change and more focused leadership, that develop more effective te tiriti partnerships within the health and disability system, and create more effective ways of working for Māori, and ensure the system is integrated and deliberately plans ahead for a longer term focus. All of that sounds good. In fact, some of it's quite amazing that we weren't doing it, if you know what I mean. Unfortunately, there was a couple of things out of scope in the review. One was ACC, which has probably come a bit closer to what those three guys were on about than the rest of the system, particularly about free care and income support when people are sick. But the other, and also ACC has been an enduring institution, and I'll talk a little bit more about why I talk about enduring institutions in a minute, because they don't all endure. But the more worrying thing from my personal point of view, just looking at the review, is that it didn't shine a light on how the political system plays into the health system. It's very hard, if you just look at the health system and see it screwing up and this, that and the other, and don't look at what are the reasons why, you'll come up with some of the wrong answers. And I felt that in understanding our health system, because we don't have a second house, because we don't have a constitution, that the interplay between the political system and the health system is extremely tight. And so you can't, and having been in it and noticing how profoundly politicians can influence the health system, even declaring whole bits of public health, like health promotion, not necessary or whatever. But anyway, but to actually look at that interface, I thought was. But apart from that, I thought they did well. My apologies for this. The technology's far too saving money. Now, on this business of health reforms, New Zealand has done it before, and so I thought I'd give you a little stride through the health system since I've been around. Don't try and grab the detail, but keep a close eye on the arrows. Okay, here we are in 1980, where we had a Board of Health, we had 18 district health officers, we had primary and community GPs who were subsidised, as they say. We had 29 boards, and we had territorial authorities involved in environmental and monitoring. Come 1992, it sort of looked a little bit like this. The subsidies had become entitlements, a bit of a change of language, and then we had the real revolutions coming into the 90s. Except some things didn't survive. The area health boards didn't survive the next round, neither did the advice to the minister. And then we came up with the Public Health Commission, regional health authorities, the Ministry of Health, etc. Contracts then applied to all bits of the sector, and that got us through 1993. And then a few of them didn't have legs. The advice was always a problem. That was looking at core, trying to decide out what the core services were so that you could say what you would get and wouldn't get. That didn't prove a very good idea. In fact, you'll find in health systems no one likes to talk about rationing because and you'll know why, because if you look at the experience in the last couple of months with rationing places and MIQs, you see why rationing's far too hard for any political system to deal with, particularly if it's sharp. But anyway, so we had a little bit of the Public Health Commission didn't have legs; it disappeared pretty quickly. As the industries involved, like tobacco, alcohol, and food, were not happy with it, of course, so then we went for another change in 1996, where we had service contracts. We got the 4 regional health authorities, etc. Now, the idea behind this is we were going to have competing purchases and competing organisations, Crown Health Enterprises. I joined Crown Health Enterprise in Tairawhiti in the 1990s. And I couldn't believe it. You know, it had a whole language and terminology, and it was a whole thing, unbelievable at the time. And I just wanted to treat people and stuff. Anyway, the old regional health authorities didn't have legs, as it happened. Neither did the Crown Health Enterprises. They weren't enterprising enough. And so then the arrows changed again in 1999, and we went for a health funding authority and 24 hospital services and service contracts, etc. We're getting advice on the National Health Committee. I haven't been following the advice. What the government focus on getting advice from changes from time to time. And this lot didn't survive very long. It got changed there. The Health Funding Authority went because it didn't seem to be a very good idea. And then So at 2000, we had the current Act that the district brought the district health boards into being, and this one is what we have at present with the current arrangements, and that brought in the district health boards, and it brought in things called primary health organisations. And what we are now moving to now is we're getting rid of district health boards, primary health organisations, and we're changing the arrows, and we're bringing in a Maori Health Authority, which in fact is probably the most exciting piece of this whole saga, actually. And I'll talk a little bit more about that. People are a bit excited at present about co-governance. It's actually an organ of the state. It's an independent state, an independent statutory authority, or that's what it's planned to be, a bit like the Broadcasting Commission or the Child Commission. Why people are so excited that suddenly it's something more than that. I think there's another one called the Drug and Sport Commission. I mean, this is a pretty regular bit of a body in the structures, so it's interesting that's causing such excitement. But I do think it's important all the same. It's a very good move, and we're also brought back a thing called a Public Health Agency in the Ministry of Health. PHOs have disappeared, DHBs have disappeared, and we've got a thing called Health New Zealand, and that's where we're looking at now. So I present that little story of structures changing, really to reinforce why I think the interface between the political system and the health system has to be looked at, and also the folly of thinking that structures really change things. People change things. The culture and the Health and Disability Review referred to the importance of culture, and I think that's a really important part. So that was my first little bit, was to just to relive a bit the history, the tremendous opportunities there are in logos, brands, marketing campaigns, and you know, in the 90s we really gave it full throttle about how often we could transform a health system. So much so, by the time we got to 2000, the health sector basically said to the politicians, do what you like, but just don't change it after that. And thankfully, we stayed stable for a while. So looking at the reforms, there was one of the aspirations of the reforms was that we would have a one system. And what we've got it doesn't quite nail it yet, and because there's a structural issue here in that we've got Health New Zealand, which will employ in excess of 80,000 health workers across the nation, and they will be employees inside industrial relations negotiations with the government, as you read every day about different groups in terms of their wage settlements, etc. But sitting outside of that, we have about 230,000 people working in the primary and community care sector without such a structure. And I think in terms of going forward to fulfil the aspirations of the reform, we've got to really look at that. Basically, how do we build an institutional stability into the primary and community care sector? Because the aspiration of the reforms is to grow the primary and community sector and to shift the focus of the health system from hospitals to the primary and community care sector. But I don't think yet we've got those ready. What's going to happen, the problem is that the powers within these structures become really important, what you might call the political economy effects in organisations. And so that will largely drive Health New Zealand. This has been a problem actually from 1938, actually, the three wise blokes. They said care should be free. The British Medical Association, forerunner of the New Zealand Medical Association, said no, we've got the right to charge. Currently, it's now the NZMA, and they've come out with an equity statement at about 2011, which is really good. But whole lots of other actors now in the sector are desperate to maintain the right to charge. So the idea that health services should be free hasn't gained much currency. But last month, the World Bank actually declared that health services should be free. So maybe there's light on the horizon. But these, what I'd call political economy effects, will really have to be managed within the reforms going forward, or we're going to end up with an increasingly hospital-centric health system, because that's the natural tendency of health systems unless you really design against it. This is just a little plug for why we need a Maori Health Authority. And I was just talking to Len earlier about data and statistics. Actually, for more than 20 years, what this tells us is that Māori women have an unmet need for primary care. And this is from the statistics, and over 40% of those, and every year since 2011, in fact every year since about 2000, but we haven't been able to do anything about it, which is quite extraordinary. The main reason they have trouble accessing care is because of cost. It's not the only reason, but it's the main reason. The fact that they don't access care when they need it means that it costs the health system a whole lot more down the track. Yet such a simple problem seems beyond us. So I'm looking forward to see how we tackle such things going forward. So that's enough of where the health system was up to. Any questions so far?
Yes, the 2014 and 15 seems to be quite low. Is there any, I was wondering, any reason for that? It seems to be lowest.
Yeah, I haven't got the confidence intervals in here, but there have been attempts to increase free care. If you think over the last 20 years, we've introduced it for increasing ages in children. So there is attempts to do it, but and in 2021, I think their sampling got a bit disturbed by the pandemic. So you've got to sort of, anything that happened during the pandemic, you've got to sort of take with a grain of salt.
No, I'm talking about 14 and 15.
Yeah.
Very low.
Yeah, I don't have. It may well be a sampling. I don't think there was a particular policy initiative in 14 or 15 that.
Kia ora, Don. I would just like to qualify. It's Prudence here.
Hi, Prudence.
Now representing Presbyterian support, but I would just like to qualify. It hasn't always just been cost. It's also a mistrust of the health system because of the institutional racism within it. You know, I'm sure that it's.
No, that's absolutely right. But the main reason is cost. But all those other, and maybe those two are actually connected as to why we can't invest in something so straightforward. Anyway, you all right there, Mike? I'll move on to what I've called virus learnings. COVID-19 has been a great teacher. In fact, the previous pandemic in 1918 reformed health systems worldwide. And I suspect in the long run COVID-19 will do the same. Well, I certainly hope so. in looking at our performance as a country, one can't but feel proud of what's been achieved. This picture here is about, we're looking here at the total excess deaths in the population during the period to April this year. And what you see there in blue is a few countries who had less deaths than they would have normally, i.e. less people died than we would have expected. And then you have a few countries who are in very dark, who have extremely high rates of death. And we know that globally, the official statistic is about 6 million people, and and most people globally don't actually get counted. We think that the death rate's probably closer to 18 million people who have died in the pandemic so far. So that's quite an extraordinary, we're in a very select club. Just ignore Papua New Guinea for a moment, that's not accurate. But us and Australia, and that's Greenland up the top, and I think you'll see Taiwan there as well. In the globe, we had two big advantages, one being an island. The other, we had more time than everyone else to observe what was happening. But overall, I think it's a result of which we should be proud. So, and think.
We also have very small population in a vast land for both countries, and we also closed the borders for a long time.
Yes, I think population density helps. And the measures that we took helped enormously about isolation and quarantine and closing borders and people staying at home and making sourdough. All those things were extremely important. So when we look here at New Zealand, just the point I was making is that we actually had a drop in expected deaths during that period, and now with COVID fairly active in the community, we're coming up. But we're still actually below expected deaths. So I thought it's worth reflecting a little bit about why that happened. But first of all, it sort of worries me that we don't really capture what that means. This is a stadium with about 10,000 people, 8 to 10,000 people. If we had the death rate in the USA and UK, that's how many people in New Zealand wouldn't be here today, which is quite significant, I think. I think it's about 50 737s, or the annual roll toll, all the annual roll tolls back over a decade or more. So, I mean, it's a very extremely important that we got that right. And any of all the things that happened, it's really out there. I mean, it's an extraordinarily tragic situation when avoidable deaths are occurring in any community. And in many countries, that's what happened. So I think New Zealand's success, for all the reasons and the reasons you're putting forward, needs to be well examined and far more intensely than what I'm doing here today. But I will give you my perspective on it. And I think it was about critical leadership at the right time, and that we were fortunate to have a leader in public health and in the political system with the required technical communication and diplomatic skills that enabled us to get together the politics, the technical requirements, and the community support to stave off the pandemic. And the reason why I think that was so important, well, one, I think we were lucky with the people, that the Director General of Public Health had the technical expertise. He also had the communication ability, and he also had the relationship with the political sector, all of which were program critical. Also, we had a Prime Minister who came into the pandemic, I should say, with a high level of public trust, and that was a fundamental ingredient. We also had which I thought was a very interesting move by the electorate and the politicians, was to bring in an someone who had months before been a infectious disease physician into the cabinet discussions following the 2020 elections. Why I bring those things out is that the qualities of those individuals are not a given in our system. And I think we need to, in thinking about health reforms, we won't always have people, we had a Prime Minister who was interested in science. You could well have had a Prime Minister who is more interested in banking. We had a technically qualified leader of the health sector. We could well have had a career civil servant who just saw it as another rise on the ladder of getting to the State Services Commission. So I think we were lucky, and I think we've actually got to design in the fact, because the critical thing here was not only public support and acceptance and understanding, but also the way science interfaces with the political system. Now, what I'm trying to say is that we had a Prime Minister who actually was really interested in the science. We brought in a health leader into Parliament who really knew the science, and that made up for some of the deficiencies we had within our public health system going into the pandemic. So in thinking going forward, we've got to design these in, because I think there was a lot of luck in those two events. And as you know, what happened in other countries wasn't quite the same. In the USA, as you know, Trump, for instance, helpfully informed the American people that it's no worse than the flu and will be over by Easter. And clearly it wasn't. And Boris was equally blasé in March before he got sick himself. He said, I was at the hospital the other night and I think there were actually a few coronavirus patients, and I shook hands with everybody. You'll be pleased to know, and I'll continue to shake hands with everybody. So, I think political leadership at that critical point is really important, becomes really important. Now, the UK Parliament has done an inquiry into what happened because of, it ranks as probably the worst public health failures in the country's history, is how the parliamentarians, even the Conservative parliamentarians, described what happened. And interestingly enough, they talked about, this is the parliamentary review, they talked about groupthink between the scientific advisors and officials. In other words, that the scientific advice became shaped by the political imperative. Now that happens in all political systems at all times. At this point, it was an absolutely fatal outcome. So, these aren't simple relationships to be talking about here, but they're incredibly important if we're to learn how we build systems going forward and how we manage, because we're going into a period, I'm sure, where the issues related to science and the issues related to politics will continue to be at tension. Our survival now depends on how we manage that tension. And so going forward, I would be very keen to make sure that in times of public health crisis, the health sector is actually led with a technically competent person. The reforms have a public health advisory committee who need to be structured and supported so that they're able to navigate that space between the health science and the politics. The second feature I was just going to talk about is the relationship between the economy and public health. In those countries that went awry, they felt that the two, public health, i.e. the health of people, and the economy were distinct and separate entities which could be managed independently. I think the pandemic has told us, if we didn't already know, that people actually are integral to the economy, and public health is integral to the economy, and if you mismanage one, you'll mismanage the other. And so globally, it's been quite expensive for the economy to mismanage public health, as we have globally mismanaged it. And according to the IMF, it's going to cost about $12.5 trillion. Cost the globe $12.5 trillion, which, so as a system learning, in public health, we've been forever putting up the economic case for tobacco control, the economic case for obesity control, and then for some reason, we then get into a discussion where, as though the economic issues and the genuine pain it causes some parts of the economy when you reduce the sale of liquor or stop selling cigarettes, gets translated as generalised into bad for the economy, when in fact the two are joined at the hip and go up and down together. And as you know, New Zealand's economy didn't do too badly in this. Oh, where did you come from? In this period. Sorry, I mean and did quite well. Since the start of the pandemic, I've been sort of collecting these ideas, and so this was my first one about what COVID could teach us. And I think the bats were trying to tell us to stop encroaching on their habitat, but I digress. I was meant to be talking at... Eh? The bat's better than this one. Yeah. Just ignore that a bit. It's the quarterly GP from 2000. What have we got here? The quarterly national. Anyway, it has New Zealand performing better than the OECD average. The economy didn't collapse because we had a public health approach. Right. The next issue I want to talk a little bit about is the issue of equity. We've struggled with equity here, but just to begin with, this, don't worry about the detail too much, but this is about vaccination rates globally. These are highly developed countries and low human development. This one's up the top left hand. How big the bars are is their level of vaccination. What it's telling us is that the global equity issues, the ability of the globe to actually vaccinate vulnerable people has been woeful in this pandemic. And in our region, we did, and our near neighbours did actually reasonably well in Polynesia. We've done appallingly in Melanesia. And so what we have here is Samoa, using this statistic at 94%, New Zealand 84%, Tonga 73%, Papua New Guinea 3.5%. Why that's important? You know, the Pacific is our neighbours, as we incorrectly say, but if the welfare of the Pacific, most of Papua New Guinea has a population of about 9 million, which is almost double New Zealand's population. The future of the Pacific, in terms of at a population level, largely sits in Melanesia, and we've got one of the most poorly performing in terms of its health system. So regionally, we've got a big equity issue. Locally, I think, you know, the big public health measures worked out well from an equity perspective because everybody got protected. However, once we moved into the health system response with vaccination and testing, etc., then the equity issues became more appellant, and we stumbled but by and large, we ended up with a very high vaccination rate. But even today, the issues of the people with boosters are actually still showing huge inequities between Māori, non-Māori, low-income people and high-income people, etc. The other interesting thing about the pandemic, well, there's millions of them, but I think we've actually, it's been a big learning curve inside the health system about how to reach marginalised folk in our community. And if you recall back the Auckland and Waikato outbreak, that developed, the initial outbreak was actually way back in March, was basically middle-class New Zealanders returning from Europe. Once we got into the latter part of the year, the outbreaks were occurring in the poorer communities, in Pacific churches, in Māori whānau, and in drug and alcohol using communities, and in the homeless. What happened globally is once those communities were impacted, most countries lost control. But there was a rapid learning that I observed from the inside anyway, where we actually then engaged critical leaders from those marginalised communities, so that you know, for instance, we engaged with gang leaders who have traditionally been vilified in the public discourse. With the help of the Kupenga Hauora Māori section of Auckland University, the Auckland Regional Public Health developed a Manaaki first approach for these communities. So in other words, when a case occurred, their approach was to engage and support rather than interrogate. Now that's simple to say, but it made an extraordinary difference. A similar approach was developed in the Waikato from the Māori Health team within the DHB. At the same time, we saw the emergence of Māori and Pacific providers, both in the provision of social care and in the delivery of vaccination. So these are, and also we were delivering care that was free, including prescriptions. So these are, we demonstrated that we know how how to do this. We have to engage, etc. What we now have to do is make that systemic. In fact, I think that period, it hasn't really been much public discussion because Omicron came along, but we actually, as far as I can see, we eliminated Delta and were one of the few countries whose response actually achieved that. And my view is that elimination occurred because of what we learnt and because of how marginalised communities were brought or were supported in the outbreak. So I think that's a real gem of a learning for us as a system in that regard. As you know, the widespread community support for the public health measures began to wane after a couple of years, if not before. And it culminated in, I think, the 23-day protest in Parliament, which was a scene that none of us had ever seen or imagined. I, with Julia, travelled from the north through to Hamilton at the same time as the convoy. And it's a scene, and every bridge on that journey was covered with supporters of the convoy. There was a very substantial piece or section of our society, a minority, but not an ignorable minority, who were really feeling alienated and isolated. Their main protest, of course, was against a public health regulatory measure. And so that's why I believe that we need a response to what was happening there in terms of the future of how regulations occur, how we communicate, etc. But apart from the presenting issue, what we observed there was a substantial minority of citizens who feel alienated from decision-making processes, distrustful of authority, and distrustful of science. I don't think we're going to solve the issues going forward unless we address that level of trust, and unless we address this issue for the vast majority of our citizens. Also, interestingly enough, and it's probably the opportunists working in the background of these organisations, they weaponise the word freedom, which I think will come to haunt the public health actions in the future. The previous way of abusing public health was talk about the nanny state. I think freedom is much more effective. And I think we need to reclaim freedom before we go too far on. So what I'm saying is that two things. One is about marginalised communities, but two about disenfranchised and disconnected communities. And these issues, I think, have to be central to policy going forward. In the reform package, I do see that there are mechanisms that could, if used, could be effective. One is the existing Whanaura policy as originally envisaged. The issues here are about the relationship and also giving agency to marginalised people. So the original Whanaura was about whānau identifying and articulating their aspirations, not the system's aspirations, but their aspirations. And then there's the system supporting the realisation of whānau's aspirations. I think a similar process and a similar learning needs to be applied more broadly. I think the monarchy first approach, where the relationship with the state needs to be recast from one of coercion to one of trust and support, is worthy of thought. And I also think that in the reforms, we've got a localities idea. There needs to be much more focus on the community side of localities. Digital maturity is all good. Equity maturity was a lot more important. And how we rebuild relationships with communities and with the marginalised in those communities becomes really important. My final remarks are of a more personal nature. I've had 2 goes of being a civil servant from 2000 to 2008, and now from 2020 to 2022. And I just want to reflect a little my personal reflections on that, and that is that the public health system, the public service has changed considerably in that period. The intensity of the media cycle is extraordinary inside the public service. And also I felt that the narrowing of focus on the stated aspirations of the government of the day, and less so on the strategic issues facing our sector. And this is consistent with what the Health and Disability System Review found when they're talking about leadership and long-term plans. And then that's, of course, carrying out the instructions of the government of the day is absolutely critical in the functioning of democracy. However, if that's all the public service does in a 3-year electoral cycle, in a complex sector, then hard things don't happen, particularly things that don't become media stories or find their way into a party manifesto. So I think we do have a problem in government, and it's also exacerbated to some extent by a lot of the thinking and policy thinking is done by external consultancy firms. These policy mercenaries, if you like, can turn a good policy to any government, anytime, anywhere. However, I mean, the problem with that is that policy is not only a written document. It's the tip of the expression of learning and understanding of a set of relationships, a shared view of what the system is and what the problem is and how we go about it. So I think we're losing that sense of the broader view of policy, so that when you look at any piece of policy, it looks okay, but then when you put it together, you find that 20 years later, equity hasn't been addressed. And we do seem to be losing or distracting our ability of central, particularly in health, to provide that leadership. So critical in the reforms is actually building the capacity and capability of the Ministry of Health to do this strategic work with the sector going forward. I think my last comment is that it is about this issue of eliminating disparities. Central to the reform is a commitment to do that. I mentioned earlier about the political economy risks sitting in the reform. If you want to improve someone's health, as we all know, you actually have to improve the determinants of health. Those determinants may be environmental, they may be commercial, they may be social, they may be cultural. So therefore we need to build institutional capacity in the health sector to more effectively leverage these determinants of health if we're going to address equity. Secondly, the importance of primary and community care in that equation equally. We have to build greater institutional stability, just as we are building institutional stability for the hospital sector. So I'll conclude there, looking forward to the discussion. These health reforms really need your engagement. They're beginning of something. There's some ideas there that are really useful, but we really have to mould them because they won't happen on their own. Kia ora.
Just, thank you very much, Don. Please give Don a round of applause. That was excellent presentation. Okay, we'll take some questions and/or comments now. I'd like everybody to use the microphone, please, and then Andre will no doubt give us if there are questions from the wider audience. Okay, so first.
My name's Debbie Leyland from UCAN, and I just wanted to ask you, talking about equality and healthcare. At the moment, we've got a thing called a pharmacy subsidy card. It's a card that you take to the chemist and you get your medications for free. Anyone in the country can get one. It's not income-based or anything. But the problem is, one of the barriers for people living in poverty is that they can't get access to their medication. And with this pharmacy card, 1st of February every year it expires, and you have to spend $100 on medications before it's reactivated. And we've been trying to fight this for over 10 years, and I'm just wondering what your thoughts are on that, and how do we actually get it so it doesn't expire, so everyone can get healthcare and medicines that they need.
Thanks, Debbie. Yeah, I did talk about the blokes in Kurau saying care could be free. And I also talked about the World Bank coming round to the idea that healthcare shouldn't have what they call in the jargon out-of-pocket payments. The story you tell about these charges, I can see the bureaucrats' hats on, saying, well, it's only $5, it's a reasonable amount to pay, it's only once a year, it's only a cup of coffee, and from the consumer's point of view, from your Debbie, what you're saying, it's not $5, it's $100. It comes once a year on top of an extremely low income, and that I'm on multiple medications, so it's not as though it's just once, and that my well-being depends on me being on those medications, so that it's really, from my perspective, from a consumer's perspective, it's really dumb. If I now then wear my overall system hat and say, we should remove all barriers for people with chronic conditions, mental health conditions, chronic disease. They have, one of the big problems is compliance. Why do we put any barriers in the road, financial barriers to accessing medicines that people require to maintain them in the community, and saves the system money? So I absolutely agree. We keep it up, Debbie, in terms of trying to get this one through.
Kia ora, Don. What a fantastic presentation. Really appreciated your noticing the political economy and the need for there to be alignment between the science and the politics. That's something that I haven't heard said often and acknowledged. My question is about, I want to know I want to also acknowledge in your presentation, you're saying in a couple of moments that it's about the people and it's about the relationships. So I want to know why the health system doesn't prioritise the major workforce, the nurses, their well-being, their professional development, their pay equity. Can you give me some rationale behind the people of the health system on the ground serving us customers, us patients, aren't getting prioritised within that system?
I'd certainly... I think you mentioned part of the issues are to do with the internal political economy and the history of health systems, and how different professional groups and different contributions are valued. I think one of the great things in the pandemic, actually, if we could call it great things, was the realisation that the people in the supermarket and folk like that are actually fundamental, and picking up the go, are fundamental in our society. And I think the same applies to nursing. Within the reforms, the aspiration always is to have better teamwork, to value individual professional skills, to have people working at the top of their scope of practice, all those things, and that they be remunerated accordingly. But it is I don't have the details, but the government is making some moves in terms of pay parity and pay equity, but I don't know the details of that.
Thank you very much, Don. I have two things I'd like you to comment on, please. One is, how do we reconcile the business side of the health system, i.e. primary care or GPs, with a public health system, which, yes, would be lovely if it were free, but... And secondly, how do we get the system talking more and acting more in terms of prevention rather than dealing with sickness that could have been prevented?
Okay, so there's quite a problem emerging within primary care as the business model, as you've pointed out, increasingly doesn't fit the reality. During the pandemic, there's been a huge revolution and move towards the virtual, for instance. And there was sort of makeshift arrangements about how that would be remunerated to get us through. But there's deeper problems now in terms of, are we paying people for the real value that they add, or are we paying them to do things that other people could do, and then not rewarding them for the real value that they add? That's why I think we need, around the primary and community care sector, a decent understanding and strategy. Otherwise, the business models, we're growing these businesses enormous. The corporatisation of the primary care sector is running apace. We develop PHOs, but then they end up, in some cases, competing with the sector they were meant to be supporting. So we have to reposition PHOs and their activities where they ought to be to add value to the system, and that needs to be a much more of a government function than a private function. So there's a number of issues related to that. In terms of your second question, remiss of me to not say, the formation of a public health agency in the Ministry of Health is really important to provide leadership around prevention. The formation of a National Public Health Services within Health New Zealand is really important to provide leadership around prevention. The formation of the Maori Health Authority can be really important about providing leadership around prevention. And as I indicated in my talk, that extends from lifestyle things like tobacco, but also wider determinants of health, which really make a difference. So I think we've got some organisational things with potential. We've got to make them work.
Is it the culture that will change?
But that's, yeah, I think the cultural change is really underdone as we're taking. There's a good attempt to have a charter, but that's with health workers. I'd like to see a charter between the health sector and the politicians. I'd like to see a charter between the health sector and their communities, where communities define much more what their aspirations for health. That's why I see the models put forward with Whanaura. We've got to give agency to people, the ability for them to meet their aspirations, as Whanaura Sen said many years ago.
Don, thanks for your talk. If the BMA in Britain could be steamrolled by Bevan to actually have general practitioners part of the National Health Service and free, and they couldn't do it here, is it still too late for us to do that? And can I ask you just one question on Maori health? If we look from, if you go right back to the flu pandemic of 1918, the disproportionality of Maori in most of our statistics is somewhat often between about 5 and 7 times. To what extent, when we look at the social determinants of health, is it possible that in New Zealand it's the other way around, that health is our failures in the health system are determining a lot of our other problems in disproportionality?
Okay. So prospects for primary... the nature of primary care is changing. That's why I'm dead keen that we get a strategic approach to it. More and more practitioners are not owner-occupiers, they're employees. We've got the rapid and great development of Māori and Pacific providers, and I think the Maori Health Authority will really boost that along. We still have an NGO sector, which in the same token. So I think, and also when I look at those 80,000 inside Health New Zealand, there is a large section, not a large section, a minority in there who are actually primary care workers, people like district nurses and community health nurses and others. So some of the building blocks are there, but we're just lacking in direction and strategy. And that's why I go back. We've got to build a sustainable institution. This talk about institutions is about having the focus so that the system learns. We'll try this, and then we can, if it doesn't work, we can do something else. It's not a set and forget, but you need the institutional arrangements so that those learnings are kept and that they're positioned so that their recommendations can be carried out. And your second question was,
Is the social determinants versus health?
Yeah.
Really, we looked at it the other way around, but we think about it differently.
Yeah, I think it's, what I would say is you can't split them. All of us are complex beings, defined by gender, ethnicity, socioeconomic status, health condition, which one of which may be my most important thing to me at any one time. And the determinants of health can't be split. Social determinants and environmental determinants and commercial determinants are all interwoven and so I think to answer that question in a particular context, I think that the health system's failure, for instance, to address the fundamental right, if you like, of Māori women to access primary care is really damaging for them. Because what the health sector can do if it's working is it can, to some extent, ameliorate the impact of failure and other determinants. I mean, if you've got a rubbish house and your kids get pneumonia and you can't go to the doctor because you've got a bill, that's the interplay of the healthcare system and the determinants. You can see it there. You've got to have a readily accessible. The kids shouldn't be getting pneumonia in the house, but if they do you want a responsive health system with no barriers whatsoever, so that they get the care that they need. Now, care for kids is free, but mum may have had a bill, so she doesn't want it. It's more complicated than that. So I think it's a context. One, I think health systems are a determinant. Two, if they're operating appropriately, they can patch up, if you like, or make up for failures and other determinants. But my third point is that we've got to look at that's why it's so important, the agency of people and communities, because it's their perception of what's important that answers your question. we want access to care, but it's actually the housing that we're worried about, or the violence on the street, or whatever the issues are.
Yes, a question from online. Do the present reform proposals have a basic statement of the purpose and the aims of a health service and the values that need to be adopted?
Yeah, I'd refer the questioner to the Whanaura bill, where those things are documented. I've got them here, but if you and from what I can see, so for instance, the bill states that the purpose of the reforms is to promote, protect and improve the health of all New Zealanders, to achieve equity by reducing health disparities among the New Zealand population groups, particularly Māori, and to build towards Whanaura healthy futures for all New Zealanders. So there's pretty clear statements, and I would say aspirational and good statements there.
Hello, my name's Sam Summers here, and I want to know, what role would nurse practitioners have with the health reforms?
Yeah, thanks for that. Nurse practitioners as part of primary care teams. So, I mean, under the health reforms aspiration, they want to shift care, more care into community settings. Nurse practitioners would play a fundamental role in that, as part of, as do other health workers, from GPs to physios to podiatrists, etc. So if the reforms aspirations are met, and you're interested in being a nurse practitioner,
Skilled people out there, including one Wellington Hospital. I think Craig's name was the one who diagnosed lateral epicondylitis, which
Yeah.
is for stretched ligament, which I found was quite good, and I told he was the best person in the building to make that diagnosis.
Great, yeah, no, the key role, yeah, so that it hopefully the reforms will make that happen.
Thanks, Don. Eileen Brown. Te tauko, what Prudence said, a fantastic presentation, and enjoyable too as well. I don't know whether you intended that, but you have that effect. I think what was really glaring to me was the lack of an institution in relation to the primary and community, and how the goals and those aspirations that you've talked about communities are going to be met with the lack of a structure that is dedicated to realising that. So what's your kind of on a good day, what do you think what should that look like, and is it achievable, because the architecture is there, so you are talking about a missing piece of, it seems, architecture that's not there to enable that to happen.
Yeah, I think we've got bits of the architecture there. If I look at PHO land, there's a range of PHOs, but there's a structural problem with them, and that is that they're not right, they're not correctly positioned within the system. So I think that there does need to be what you might call a mesostructure for primary and community care. We do have bits of it, but it hasn't been a particular feature in this design. And I think it's something that needs to be built going forward. And as I mentioned, in 2000 we thought that was PHOs. And then if you'll recall, what happened is that we had community members on PHOs, and that got removed, I think, around 2010. And then they became, some of them some of them were just a post box. Some of them were quite dynamic and innovative, and in all sorts of areas and supportive of the practices. And we've also got a situation now where some of them are actually in competition with other parts of the sector. So that all needs to be tidied up, if you like. But more fundamentally, at each level, at the strategic level, there needs to be a focus on primary and community care so that because I know we're going to have a big focus on hospital care.
Hello, Don. Thank you very much for your wonderful presentation. My name's Gail Duncan, and I'm co-president of the Public Health Association New Zealand. And first of all, I'd just like to offer a bit of information for you regarding the nurses' pay agreements and things. And I think the Fair Pay Agreements bill that's making its process, if that gets through, will help with across the board, including nurses, with improving their pay and conditions. But my question is that I was given that the team of 5 million all working together with our preventative things like masks and our understandings of the basics in health has possibly been part of that bringing down of our death rate overall, because our influenza and other things disappeared. I wonder, given that context, if you could explain how the new Public Health Authority could be functioning in this new system to help every New Zealander pick up their banner for public health and keep moving in the wonderful direction we've done in the last 2 years. Thank you.
Yeah, thanks for that question. And the points you make about the team of 5 million, fundamentally, I did pick out the leaders to mention them, but the other 5 million were actually far more important. And also the way different communities responded was just so exciting to see. And we created a number of conditions that were quite different from business as usual. We found that there was a thing called COVID money, which was different from ordinary money. Suddenly the homeless could be housed. Suddenly, the entire nation was focused on the immunisation rate of Ruatoria and Aohipara. So there was a sort of weird, self-interested at times, shifting in priorities. One, I think it's really important. This is why I think the key to it, I mentioned in my presentation, is if we see what's happening in similar political systems, UK, USA, when things can go very wrong, this issue, and for public health, it's also an issue, is that if we want the 5 million, we actually have to have a relationship with the 5 million. And that relationship has to be well led, hence a public health agency, and well operated, hence how public health in the broad operates through Health New Zealand, not only the public health sector, but the other parts of Health New Zealand where we're talking about hospitals, primary care, community care, etc. So I think, I don't draw a big line between health services and public health, that it's a continuum, and that that the reforms fundamentally have to recast that relationship with the 5 million. And it's not about telling them what to do, it's about listening to what their aspirations are and working with them on it.
Yes.
We'll take one more question after that.
From Lee Tan on YouTube. How does the health reforms address the critical shortage of health professionals in rural communities?
Thank you, Lee. That's a good question. I think what you in my answer to that is really about what priorities are and what priority is given. So there's a big focus on equity. One of the equity issues is about rural areas. And so the health reforms give a focus on equity. The structures have yet to determine, hence again I'll come back to why primary and community care is so important, have yet to focus how something like rural health services, and particularly Māori rural health services, but I think there's hope there. There's a place for it. I mean, and particularly where Lee's familiar with I think the Maori Health Authority will be extremely important, because iwi and partnership boards, iwi have an interest, from what I can see, have an interest in three populations. They have an interest in the population in their rohi, in their area. They have an interest in all the people that whakapapa to that iwi across the nation and even in Australia. And they also have a manaaki interest in terms of health services for non-iwi members in their area of jurisdiction. So I think that's quite that will be a key positive lever to bring up the issues of rural areas, because the geographic, how iwi are situated and their relationship to the land.
Okay, well, I'd like to say ngā mihi kia koutou, ngā mihi to you, Don, for a fantastic presentation. I think the lessons that I've taken is that, as you said, the politics, the science, the structures all have to come together on the basic focus of equity, and I think around the idea you're developing of Whanaura and community. And if we can build a health system that puts all of those learnings from this exercise into place and doesn't take a institutional or a consultative kind of approach, that will be a huge benefit and a lesson well learned for all of us. So once again, thank you very much, and please give them a round of applause. Good night.